PET in management of patients known to have coronary artery disease, the advantages of PET over the other non-invasive cardiac modality in evaluation of coronary artery disease, and finally we will touch base on the future application of positron emission tomography in the management of coronary artery disease. So the first question that comes to mind whenever we come across the non-invasive cardiac modalities is, do we need non-invasive tests for evaluation of patients with suspected coronary artery disease? With the most recent advances in invasive coronary angiography, we have a lot of radial approaches that are advocated by the societies, less complication, and so far it is the gold standard in the anatomic evaluation of coronary artery disease. Therefore, we could ask this question, do we need it at this stage? Now, if you look at this registry from the United States, looking at the NCDR, close to 2 million patients in 663 centers that went in for invasive coronary angiography for evaluation of chest pain, only 37.6% of patients had intervention. So the majority of these patients underwent invasive procedure to come up with a diagnosis that can be easily and adequately made without the invasiveness. Now, we can ask the second question. In the era of advanced CT coronary angiography, do we need functional testing for evaluation of patients with suspected coronary artery disease? And if you allow me to refer you to the FAME trial, in which the patients have both anatomical evaluation based on visual assessment as well as functional assessment by fractional flow reserve. And in the group of patients that were labeled to have 71 to 90% stenosis, and if I may remind the audience that away from left main, anything above 70% is considered to be stenosis. Functionally, only 20% of this group of patients have functional evidence of stenosis to require intervention. And therefore, the majority of those who are labeled to have significant coronary artery disease end up not having significant coronary artery disease. So how do we do PET? It depends on the vasodilator that we use. If you use Regadenoson, you might finish this test itself in 17 minutes. Diberidamol may increase it to 30 minutes. We usually do a scout images, then inject rubidium, do list mode, and then give for rest imaging, give Regadenoson, do again list mode for stress images, and do cardiac CT. We will see at the end, let me just probably use this better. Okay, so you can see here, we will see the relative perfusion images, the gated images for the function, flow, and CT, and then finally calcium score. So what is the role of PET in the management of patients with suspected coronary artery disease? Let me go with you through this case. 61-year-old gentleman referred for perioperative cardiac evaluation prior to liver transplant. His past medical history is significant for diabetes, hypertension, and osteoarthritis. Clinical examination was unremarkable. Echo showed normal LV ejection fraction with no significant valvular pathology, and his ECG was normal. He underwent Regadenoson stress scan. As you can see, there is basically what we do in this scan. The first row is usually the stress. The lower row is the rest, and we compare stress to rest, and if there is a discrepancy, then this leads to inducible ischemia by the stress test. And as you can see, the entire anterior wall has significant ischemia, as well as the lateral wall, which give us a suggestion that this patient either have left main coronary artery disease or two-vessel disease involving the left anterior descending artery and left circumflex coronary artery disease. His ejection fraction was low with some regional wall motion abnormality, and his flows were all abnormal. He underwent coronary angiography, and as you can see, the patient has significant left main coronary artery disease. Another gentleman, 45-year-old male, referred for evaluation of atypical chest pain. His past medical history is significant only for hypertension. His clinical examination was unremarkable, normal echo, normal ECG. We did a PET study, and as you can see, we have a full donut on the top, a full horseshoe up and down, and the bottom tells me that the perfusion is normal, his ejection fraction was normal, and his CFR was normal. So the patient was reassured that chest pain is very unlikely to be cardiac, and he was advised to pursue healthy lifestyle. Back in the clinic after some time, asking for a new technology that he read about in the WhatsApp called cardiac CT. Tried to reassure him, we failed miserably. So we did a cardiac CT for him to reassure him because this is his right. And look at his anatomy. Its anatomy is normal, which speaks to the same finding that we have in positron emission tomography. So in terms of the diagnostic accuracy of PET myocardial perfusion imaging, we know that from the latest paper by McCardle et al., looking at almost 3,000 patients, the sensitivity is 90% and specificity is 88%. And this has been also demonstrated in a larger group of patients, looking at almost 1,200 patients, 12,000 patients, in which the sensitivity was 92% and specificity was 82%. What about the prognostic value? Because whenever we see a patient with coronary artery disease, we speak about diagnosis and we speak about prognosis. And this is a graph that shows you the more of ischemic burden we have, the poor the outcome of the patient. If the patient has a normal scan, which means that he does not have any myocardial perfusion imaging abnormality, then the likelihood of him having an abnormality within the next year or within the next year is less than 0.1%. And those patients who have more than 10% have incremental risk of death and non-fatal myocardial infarction. So now, what is the role of PET in the management of patients with known coronary artery disease? And I will share this case with you. A 75-year-old male known to have coronary artery disease. He had myocardial infarction in the past. He cannot remember when and how he was managed, but he cannot recall invasive coronary angiography. He presented with chest pain and exertional shortness of breath. However, although his clinical examination was normal, a part of signs of volume overload heart failure, his creatinine was 178%. So ideally, this patient has high likelihood of disease before we get him to the test, and probably the most appropriate test would be getting him into invasive coronary angiography. However, we have a caveat here that his creatinine is high, and if we subject him to the dye, we might actually worsen his kidney function. That will play a major role in his outcome thereafter. We did a PET scan. As you can see, there is some ischemia, because there are some differences between in the inferior wall between stress and rest, but his ischemic burden was less than 7.3%. And we know from Courage nuclear sub-study that those patients who have ischemic burden more than 10% are likely to have poor outcome compared to those less than 10%, and this patient was treated medically, and therefore we save his kidney, and hopefully we save his life. This is his ejection fraction showing what we have demonstrated earlier. So in terms of outcome, this is again the first paper that looked at the ischemic burden by Hashimovich, in which he advocated that now 12.5%, or let's make it 10 to 12%, ischemic burden is an indication for invasive therapy. LV ejection fraction, if the patient has a drop of ejection fraction from arrest and stress, then there is an indication that he has significant three-vessel disease or left main disease. In our population, when we looked at it, knowing that our population have higher risk profile, especially with the high risk of diabetes and hypertension and dyslipidemia, the cutoff was 3%. Now, what are the advantages of PET over SPECT? That's a valid answer, a valid question. It has a better spatial resolution, has faster image acquisition, lower radiation. With rubidium PET, we have something around 3 millisievert, compared to 10 millisievert of radiation if you use low dose reduction algorithm. But if you use the conventional algorithm, the radiation might go up to 28 millisievert. Hiroshima survival received 50 millisievert, so you could imagine the amount of radiation that we have. Then we have accurate evaluation of ischemia, as well as evaluation of myocardial blood flow and coronary flow reserve. And let me just share another case with you. A 55-year-old female complaining of exertional shortness of breath. She could exercise in the past, underwent exercise single photon emission computerized tomography, which was showed normal perfusion and normal AF. Her past medical history is significant for diabetes and hypertension and dyslipidemia, unremarkable clinical exam. She came again with chest pain, so we have to do something for her, knowing that she's a female and females are more likely to have endothelial dysfunction and spasm rather than anatomical stenosis. We decided to do PET, and as you can see, the PET here is normal, which is classical to the one that was seen with SPECT. Ejection fraction was normal, however, look at her flows. Anything of the coronary flow reserve more than 2 is considered normal, but all her clinical, flow reserve on all the territories are low, at 1.4. And when we do coronary angiography, she had significant LAD disease that was stented. So the PET has an advantage to look at microcirculation and to get us an idea whether the patient has responded to vasodilator and calculation of CVR, which has a prognostic value. We can plot the finding to see whether this patient has a severe, moderate, mild ischemia, or he's normal, or endothelial dysfunction. And we know that these have a prognosis factor at any level of ischemia detected. So in terms of Y PET over SPECT, this is the coronary tree showing the large and medium-sized vessel and microvessel. Coronary angiography will tell you this much. CT angiography will tell you this much. SPECT will tell you this much, but PET will tell you that much. It was a comprehensive evaluation of all the coronary tree. Now, another factor in assessment of patient with coronary artery disease is the assessment of viability. And this we do metabolic imaging in order to assess the viability of the patient. And because of sake of time, I'm going to give you an image here, which shows that here is the rest, rubidium has the rest FDG. And as you can see, we can have either a match defect in both imaging, telling me that this patient has a scar, or a mismatch effect like here, which tells you that the patient has viability. And I'll give you a case, 62-year-old patient presented with shortness of breath, lower limb edema. He's known to have coronary artery disease. He has PCI to the LAD in the past, presented with classical heart failure with volume overload. We did his echo, which showed ejection fraction to 30–35%. And this is coronary anatomy. He has significant disease in the LAD and significant disease in the RCA. But when we did the viability scan on this gentleman, his LAD was viable, but as you can see, there is a match defect in the inferior wall telling us that his RCA is non-viable, and therefore there is no need to open the hose on a garden that is already dead. And what we did, we just stented his LAD, and therefore his symptoms have resolved. So this program has a lot about circulatory support, so I couldn't help myself by presenting these cases. So PET has a very promising role in evaluation of device infection, again through the metabolic imaging with FDG, and these are examples of LVAD infection at the exit level, at the drive line, as well as the pump pocket level. And these are actually have been associated again with prognosis. So what are the future applications? We have now more tracers to give us a better assessment of blood flow. We have increasing evidence that the blood flow might help us in evaluation of patients as well as prognosticate them. And there is a lot of work in metabolic imaging looking at the other parameters of angiogenesis and stem cell treatment. So in conclusion, cardiac PET has emerged as an important tool in the management of patients with coronary artery disease. It can help in the diagnosis of those with suspected CAD, quantification of ischemic burden in those with known CAD, guiding the revascularization, evaluation of coronary flow reserve, and has limitless future in the field of molecular and metabolic imaging. And with this, I conclude. Thank you so much.